Let's jump right in. Picture a 57-year-old family of four. They've planned, they've saved, and they are finally ready to exit the workforce and retire early. But in America, looking ahead to the year 2026, the cost for this family to simply maintain standard health insurance for the next 8 years, it is a staggering $24,000 annually. Welcome to this explainer on the $24,000 retirement healthcare cliff. We are going to dive deep into the structural math of early retirement. $24,000. That isn't just a number. It represents the single biggest structural obstacle that early retirees absolutely must calculate before officially stepping away from their careers. It is this invisible hurdle sitting right in the middle of standard financial planning, and honestly, it's often totally overlooked until it is just too late to adjust. And this brilliantly illustrates the massive global variance at play here. For the exact same family profile, in the exact same year, purchasing the exact same baseline coverage tier in Taiwan costs around $3,600 annually. That is a massive 6.7 times cost multiplier. It practically forces us to take a serious analytical look at how healthcare is actually priced globally for retirees. So here is the analytical framework we'll be walking through today. First, the pre-Medicare gap. Second, the 2026 subsidy cliff. Third, a global comparison. Fourth, the hidden Maji trap. Fifth, the case for staying. And finally, pricing optionality. Section 1, the pre-Medicare jack. Okay, let's dive into this. What exactly are we talking about here? This gap affects approximately 1.3 million Americans every single year. Basically, it's that stretch of time between the exact day someone loses their subsidized employer health coverage, usually around ages 55 to 62, and their 65th birthday, which is when Medicare finally kicks in. For early retirees, this creates an unforgiving 3 to 10-year period of complete, unshielded exposure to market-rate medical premiums. Section 2, the 2026 subsidy cliff. Now, the severity of this exposure just shifted in a very big way. A quiet legislative expiration recently increased these gap costs by an average of 18%, and in some cases, it literally doubled them. Let's look at the timeline. Prior to 2021, there was a strict cliff right at 400% of the federal poverty level. Then, from 2021 to through 2025, enhanced tax credits acted as a protective shield, capping premiums at 8.5% of income. But on January 1st, 2026, that cap completely vanished, bringing that rigid, harsh cutoff right back. The current reality of this restored cliff is incredibly sharp. We are talking about an income cutoff line sitting at roughly $85,000 for a couple and about $128,000 for a family of four. The absolutely crucial mechanism to understand here is that the subsidy does not gradually taper off. It instantly disappears. Earning just one single dollar over that line means you are paying the full unsubsidized premium. To put that into perspective, crossing this line leaves a 55 to 64-year-old in Florida paying roughly $1,750 a month per person. For an older family of four, that escalates to over $22,600 a year. When we zoom out and look at the entire gap period, the mathematics are simply staggering. $250,000. For a couple retiring at age 55 without a subsidy, the financial reality of a 10-year gap mathematically equals $250,000 in premium costs alone. That is a massive chunk of change subtracted right out of a retirement portfolio before a single doctor is visited or a single prescription is even filled. Section 3, global comparison. Now, what's really interesting about this slide is when you compare that $250,000 reality to international alternatives. The geo-arbitrage data gives us a totally different perspective. Looking neutrally at a broader 11-country dataset, an unsubsidized family in the US benchmarks at $2,000 a month. Just below that is Singapore at $1,650. Then we see developing nations ranging from $500 to $800, but look at developed nations like Portugal dropping down to a tight cluster around $400. And at the very bottom, Taiwan, costing just $300 a month. Visually, the spread here is immense. An expatriate living in Taiwan on a gold card visa pays less than $50 per person for world-class medical care. Their premiums are mathematically capped at roughly 4.7% of their monthly income. We are talking about the exact same coverage goal achieved for drastically different capital allocations. But this data also reveals what we can call the Singapore anomaly. Normally, you'd assume rich countries have expensive healthcare and developing countries are cheap, right? Well, Singapore breaks that rule entirely. The true cost variable isn't a country's GDP, it's integration. In Singapore, expats are forced into private international plans that average nearly $20,000 a year. But in a place like Portugal, expats integrate seamlessly into the free public system, and they just add a cheap private supplement for somewhere between 30 and €150 a month. Section 4. The hidden Maji trap. So the crucial point is, for those deciding to remain stateside, navigating the Affordable Care Act presents a really tricky secondary complication. You have to understand exactly what counts toward that income cutoff. Subsidies are determined by your modified adjusted gross income, or MAGI. And guess what? This includes Roth conversions, capital gains realizations, and dividend income. Every single dollar drawn from a standard $2 million tax-deferred IRA to live on counts directly toward that MAGI limit. And this creates a cascading, almost disastrous sequence of financial events. First, a retiree draws standard living expenses from a tax-deferred account. Second, if they pull just slightly too much, they cross that strict MAGI threshold. Third, they instantly lose all ACA subsidies. And fourth, they are hit with the full, unsubsidized healthcare premium right on top of the ordinary income tax they already owe on the withdrawal. Poor tax-aware withdrawal sequencing in 2026 transforms what used to be a minor spreadsheet mistake into a massive, five-figure unforced mathematical error. Section 5. The case for staying. Now, objectively, we have to acknowledge that healthcare decisions are never entirely isolated to spreadsheet math. The variables of actually moving abroad are highly complex. For one, care quality varies wildly. Treating a complex cardiac event in Boston is vastly different than treating it in rural Costa Rica. Also, 40 years of medical records and health history do not transfer easily across borders. Plus, optimizing a spreadsheet quickly loses its appeal if it means living 8,000 miles away from your grandchildren. On top of all that, the reversibility risk of coming back to the U.S. to establish Medicare at age 75 is a very messy process. And let's not forget the tax compliance overhead. Things like FBRs, FATCA, and exit taxes never seem to appear in those neat little premium comparison tables. Section 6. Pricing optionality. Let's move to and see how this all builds together. Given the massive costs of the U.S. subsidy cliff and the genuinely complex realities of moving abroad, a pragmatic, engineering-minded framework is really required here. We don't have to rely on one-size-fits-all mandates. The optimal strategy isn't necessarily about forced relocation. It's about analyzing residency pathways as a mathematical hedge against policy changes. The core thesis here is simple. Price the optionality. Establishing a second residency pathway requires some serious lead time, typically taking anywhere from 6 to 18 months. We're talking about programs like Taiwan's Gold Card, Portugal's D7 visa, Malaysia's MM2H, or various pensionado programs across Latin America. By initiating these processes early, say between the ages of 50 and 55, a retiree creates immense leverage. When they reach age 62, they are empowered to make a fully informed decision based on their actual health, their family situation, and the exact U.S. policy environment at that specific moment. The reality is, the absolute cost of securing a secondary visa, of basically just opening the door, is remarkably small compared to the massive exposure of the pre-Medicare gap. Having these options effectively mitigates the risk of walking blindly into a $250,000 premium liability. You absolutely do not have to walk through the door, but you must have the key. So, to wrap up, reflect on the data presented today. Which global premium data point challenged your assumptions the most? Or, strategically, which residency pathway now demands a deeper layer of research for your own planning? If this structural breakdown of money, policy, and reality proved valuable to you, make sure to subscribe for more data-driven explainers.